Hello, everyone, and welcome to the next in the recent graduate series of presentations. So today we've got Thoracic Emergencies, How to Breathe More Easily, which is going to be run by Helen Wilson, who is our ECC diplomat, who runs our ICU here at Langford, and Catherine Tyndale, who's one of our final year surgery residents. Just to remind everyone, there will be a Padlet afterwards, which we'll send the link round for, and that'll be live for a month after the webinar, so throughout all of August. And we do encourage you to try and get on there and write some questions for our speakers and for the rest of the team here, just so everyone can benefit from any questions you may have following the presentation. So I'll hand over to Helen and Catherine now, and hopefully this will be another really useful seminar for everyone.
Thanks very much, Lee. We'll get stuck right in. So we're going to present a couple of different cases for you this evening, both related to thoracic emergencies. And I'm going to let Catherine kick off with this first one.
Great. So we've got Sally, and she's a 1-year-old female neutered Sphinx cat. And Sally presented one evening, and this is how she looked when she came in. So Helen, what do you think about Sally on presentation?
Well, I think it's clear, isn't it, that she's pretty dyspneic. You can see that she's really struggling here. She's got really quite a marked inspiratory effort. You can see her ribs there. Being a Sphinx, you can really see the effort that she's putting in to breathe. You can see that her mentation's not really completely normal, and that's really because she's just focusing all of her efforts on trying to breathe, and you can see the body position there. She's got her elbow because she's just capacity within her thorax to try to improve her breathing. So I would call this a restrictive respiratory pattern, which is defined as short, shallow breaths, as opposed to those sort of upper respiratory tract Boesi type dogs, which take longer, deeper breaths, which is called an obstructive pattern. This restrictive pattern is often more associated with either pulmonary disease or pleural space disease. So I would be concerned that we've got an issue in the thoracic cavity itself going on here.
So what sorts of thoracic diseases are on your list at this stage?
So I think I'd definitely be considering, I definitely have pleural space disease pretty high up on the list. And for cats, I'm going to be thinking, could this be congestive heart failure? Could this be pyothorax? Could it be a chylothorax, a pneumothorax potentially? Anything that's resulting in fluid within the chest, or alternatively, could this be a pneumothorax? Particularly if this were a cat with a history of asthma, then they can often present with a pneumothorax, or a cat that's had a trauma. And then in terms of pulmonary diseases, I would be thinking, could this be a form of pneumonia, either aspiration pneumonia, though that's quite uncommon in cats, or a form of infectious pneumonia, either bacterial or viral. Whole host of viruses in cats can cause pneumonias. Or could this be something more localized, like a pulmonary abscess or a foreign the lungs, or even neoplasia affecting the lungs? I would also have feline asthma on the list, although that is a common presentation for a dyspneic cat.
When you have one of these cats present into your ICU, what's sort of your order of preferences to how you treat these cats and get them more stable?
Yeah, great question. And I think probably the first thing to say always with any dyspneic patient, dog or cat, is that we always want to provide oxygen for these patients before we do anything else. These patients are often very fragile, on a knife edge. Particularly cats, anything that we do to stress them out can just tip them over the edge, and they can arrest as a result. So oxygen is really important to do first, and to provide it in the least stressful way possible. So you can see that we're providing this cat in the video with some flow by oxygen, and you'll notice there is a face mask on here, but it's not actually over the cat's face. Often cats find that really, really stressful to have something put over their face. They can freak out. It can cause them to consume more oxygen in the process of freaking out and using extra muscle activity, and that can actually cause them to arrest. So flow by oxygen just going past the nose and the mouth is really good in this type of initial presentation, because it allows you to have the patient out on the table so that you can assess them more thoroughly while still providing oxygen. In some instances, it's not even appropriate to do that, and actually you just need to put the cat into some kind of oxygen tent and allow them to calm down for a few minutes after the stress of transport to the vets before you do anything with them at all. So just taking a really hands-off approach is really important with these patients.
I suppose you then got to make your decision about what you're going to do next, and you get quite a big long list of possible things that could be going on with this cat. What's sort of the first kind of steps of investigations that you can do quite easily to try and give yourself a bit more information?
Yeah, and I think it's a great question, and I think just being able to look at the cat and help to localize where the problem is likely to be based on just observing the respiratory pattern is really important, because that helps you to then target your diagnostics at, in this case, the thoracic cavity specifically. So you can start to pick and choose what you're going to do next, and when it's safe to do that, then really we want to start to gather some information about what's going on in that chest. And we could do that by, if we suspect pleural space disease, particularly in terms of auscultating the patient, can we hear dull lung sounds ventrally that would suggest pleural effusion, dull lung sounds dorsally that might suggest a pneumothorax? Then we could just go ahead and do an endothoracentesis, which is both a diagnostic and a therapeutic step to see if we get anything back. But equally, we could, if we've got ultrasound readily available, we could do a point of care ultrasound of this cat's chest, again, to see, is there obvious pleural fluid in there, yes or no? So I would start by auscultating the cat. And then if we were going to move on to a point of care ultrasound, which often we will, because everybody has ultrasound widely available nowadays, I think it gives people reassurance to, if they're going to stick a needle in the chest, to just be able to say, yes, there's a big pocket of fluid, I'm sticking the needle into that and not into the heart. So we did go ahead and do a point of care ultrasound of this cat, and you can see that on the screen here. And what we've got going on here, you can see the heart beating in the middle, and you can see that it's just swimming in a fluid, in a sea of fluid. And you don't have to be an ultrasonographer to do a point of care ultrasound. All you have to know is that fluid is black. That's all you need to know. And you can see that the heart is surrounded by lots of black. That's all fluid. This little hyperechoic string that looks like it's coming off the heart, this is fibrous debris. It's really common to see that in all types of pleural effusion, and you don't need to worry if you see that. That's quite a normal finding, but essentially we've got a large volume pleural effusion here, so we can feel fairly confident that we should go and stick a needle into this and drain it. And the joy of using point of care ultrasound is that you can choose where the biggest pocket of fluid is to stick your needle into, so that you can feel very confident that you're not going to be sticking your needle into the lungs or the heart or anything else that you don't want to accidentally poke in the thorax. This is just a still image, just to show you. This is the heart over here on the left hand side, and then this hyperechoic line over here is the diaphragm, and this just shows you that the diaphragmatic recess, which is this triangle in between the heart and the diaphragm, is the place where fluid is most commonly going to accumulate. This is the most dependent point of the chest, and so if you are going to see fluid, this is the area that you want to look in, just caudal to the heart and just cranial to the diaphragm.
So you've talked about wanting to maybe take a sample remove some of this fluid to help the cat out.
Yeah.
Technically, how are we going about that?
Okay, fine. So what are we going to do next? We're going to, there's lots of different ways that we can remove the fluid, but probably the most straightforward way, and I think the safest way is usually the most straightforward way, is to do a needle thoracentesis. And I like to do that with a butterfly needle and a 3-way tap and a syringe. And that's a nice, simple, straightforward setup. Most people have that equipment available in their practice. You can do it just with 2 people, 1 holding the cat and 1 draining the chest. If you've got 3 people, even better, because it's actually easiest if 1 person puts the needle into the chest and then the other, a second person is operating the 3-way tap and the syringe. But you can absolutely do that all by yourself if you need to. So as we've said, we're going to use point of care ultrasound to identify where the biggest pocket of fluid is, and then we're just going to aim for that. And you don't need to do it truly ultrasound guided in the sense that you don't need to hold the probe as you stick the needle in. You can just make a mental note of where on the chest is the biggest, deepest pocket of fluid and just aim for that location. If you don't have point of care ultrasound available, it's absolutely fine to do this blind. If you identify that there are dull lung sounds ventrally, it's completely reasonable to just go for it, stick a needle into the chest. If you get a negative tap, that's a diagnostic result, it's not a failure. So it's completely fine to just go for it and try and do it, a blind thoracentesis. And if you were going to do it blind like that, then you would want to aim for between the 7th and 9th ribs. And you want to aim for the ventral third of the chest, and really as ventrally as you can go, because the fluid is going to accumulate dependently within the chest. And so as low as you can get the needle, it's going to give you the best chance of getting that fluid in a blind fashion.
Because obviously it's all prepped and nice and ready and hairless for you, but how extensive and what preparation do you need to do prior to these thoracic?
It's a good point. You want to have a big enough clip patch that you're not introducing extra contamination into the chest. So definitely want to clip it, do a sterile prep. I prefer to wear sterile gloves while you're doing it, because if you are sort of, you know, poking where you're going to stick the needle in, then you want to stay nice and sterile. I like to use the glove packet as a sort of a little sterile tray just next to the cat as well. You don't necessarily have to drape the patient for this, but it is a good idea to wear sterile. I would generally do a clip patch that's sort of, for a cat, since they're not very big, probably sort of as long as the thorax, to be honest. So you want a decent size clip patch to make sure that you're not going to be, the last thing that you want to do is to tap a cat's thorax and then create a pyothorax in the process of doing it. That's always a disappointing outcome. So I actually have a video here of draining a chest with a butterfly needle set up. So you can see we've got a butterfly needle going into the chest here, and we're wearing sterile gloves. We've actually put some extension tubing on this, mostly just because there were quite a lot of people around this cat and we just need a little bit more distance. But you don't have to have that extra extension tubing. You can just connect that 3-way tap straight onto the butterfly needle. And so you'll notice that with this 3-way tap, we've got it turned on at the moment between the patient and the syringe. And when this syringe is full, we're going to turn it through 90 degrees. There it is. It's connected, that syringe is because actually we were taking that first sample, that first bit of fluid as a sample that we were just putting into some pots just out of the shop there to send to the lab for analysis. But mostly we don't disconnect from that 3-way tap. You can just turn the 3-way tap and empty it into a kidney bowl, as you'll see in a moment. One of the things to just times, despite even with a cat's chest being not very deep, it can be surprisingly difficult to get the needle all the way through to pop through into the pleural space. And sometimes if you're not getting any fluid back, just need to push a little bit harder. Even if it feels like you're putting excessive pressure on the chest, sometimes you just need to push a little bit harder to pop that needle through into the pleural space to get that fluid coming back. And then generally we would just stay nice and still in this position until we've completely drained as much as we can. So we just drain it until it's dry and then check again with ultrasound to make sure that we can't see any fluid left. And normally there'll be a tiny, tiny sliver left. You can't get all of it out, but there should be minimal fluid left at the end.
And you said you took a sample of this fluid. So what are you doing with that sample?
So generally speaking, I always like to do cytology of the fluid. And I always want to do cytology in-house, because if you have to send it away, especially if it's got to go in the post to an external lab, you don't want to wait for several days for those results to come back to find out that the cat has a pyothorax, because really, if there's bacteria in there, you want to know that as soon as possible so that you can start some appropriate treatment with antibiotics as soon as possible. So I always like to look myself at the sample in-house so that I know straight away whether there's loads of bacteria in there or not. If I'm not seeing lots of intracellular bacteria, then definitely I would still want to send that fluid away to be analysed by a clinical pathologist to see what other cells are there. Identifying neoplastic cells in effusions can be really very challenging, especially because mesothelial cells can become very reactive and it's very easy, like they're neoplastic with lots of nuclei, and actually to a clinical pathologist they can identify that that's not a neoplastic effusion. So it's quite easy to be misled by cytology in-house. So I'm literally bugs in there. Everything else I'm sending off to the lab. And then if I've got any suspicion at all that this is going to be a pyothorax, then I like to send it to the lab for culture and sensitivity as well, because ultimately we want to know if there are bugs there, what antibiotics are they sensitive to? And even though we're going to make an empiric choice about what antibiotics to use in that scenario, we still want confirmation that the cat is on the correct antibiotics, and actually we may well want to narrow down the spectrum of antibiotics. So I think it's really important to send off always for both cytology and culture and sensitivity. And then we might do additional tests depending on what our clinical suspicion is. If we think that this could be, for example, a chylothorax, we might want to request cholesterol and triglycerides as well. So other situation dependent tests may be necessary. I think one of the most important things with any type of fluid, be it pleural or abdominal fluid, is to remember that no matter what the fluid looks like, you can't assume what it is based on its gross appearance. So you might be highly suspicious that it's going to be a pyothorax if it's brown, like this in this photograph here, but you can't know that until you've analysed it. And actually it could still be chyle, it could still be heart failure, like you just can't tell from its gross appearance. So it's super important to always analyse the fluid and not make an assumption what it is, and particularly because you can have multiple fluid types appearing together. So for example, you could have chylothorax that has a secondary infection and is a chylopyothorax. So for all these reasons, it's really important to always analyse it cytologically and biochemically. So this is what we're looking for when we say that we're talking about intracellular bacteria. So we're looking for bacteria within neutrophils, and you can see that on a diff-quick stain, the bacteria will stain with a purple appearance, a basophilic appearance, and you can see that there's a mixture here of cocci and rods, and often if this is an infective fluid, you'll see a lot of intracellular bacteria.
And why are you looking for them specifically intracellular?
Because, excellent question, because if they're extracellular bacteria, so they have not been phagocytosed by neutrophils, then those could just be contaminants. So we could have introduced those from the skin, for example, as we put the needle through into the thorax. So the fact that they're appearing intracellular means that the body has made an active response to the presence of those bacteria, which is the criteria for confirmation of an infectious process. So that's why we need to see them being intracellular. And in fact, you can see there is one here hanging out that is extracellular. And if we only saw that bacteria, we wouldn't be able to say that this is a pyothorax. But because we've got lots of bacteria that are very clearly within the cytoplasm of cells here, we can confidently say that this cat has a pyothorax. Okay, so now what do we do? The big dilemma. Do we choose medical management
or surgical management?
Or surgical management? And I guess here comes the debate, because there isn't a hugely clear difference in outcome between the two approaches, and there's pros and cons to both. Medical management is obviously less invasive than surgical management, but they don't always do well with medical management. It can fail and they can still need surgery downstream, which can, to the owners, mean much higher cost overall. And then
from a surgical perspective, it might mean that we can actually treat them in a shorter time frame and get them back to their usual lives much more quickly than particularly if we end up at medical treatment and then end up at surgical treatment after that. Indeed.
Indeed. And there are some things that we look for with these patients, which we do consider to be more along the lines of clear surgical indications. So when we're working these patients up, we're looking for evidence of abscessation, either within the lungs or the mediastinum, because it's unlikely, if you've got a big walled off abscess, it's really unlikely that antibiotics alone are going to penetrate that sufficiently to kill all the bacteria to result in a good outcome. And so typically, if we're seeing that on imaging, we are more inclined to do surgical management with those patients. And equally, if we see clear evidence of a foreign body, then that would lead us more to think surgical management. However, how often have you seen a foreign body on CT?
Yeah, not usually.
It's pretty uncommon. Normally, we don't see it, even if there is one present, often because by the time a foreign body has been introduced, and then by the time an infection has brewed, actually whatever bit of organic material got in there in the first place has become macerated, and you're never going to find it. And usually we don't even find it at surgery, do we?
And even if we do find it at surgery and it's, 2 or 3 centimeters long, you can still go back to the scans and think, no, still can't find it on there because it's the same colors as everything else.
Yeah. So it can be quite difficult to identify whether there's a foreign body or not. And I guess in cats, we generally think they're a bit less likely to have foreign bodies than dogs as the cause of a pyothorax, and perhaps more likely that it's been introduced by fighting with another cat and either a tooth or a claw penetrating the thorax.
So if we are going to go down the medical treatment route,
yeah,
what's your kind of route? What are you going to do? How are we going to help this cat?
So my preference would always be, if we're going to do medical management, to do it by placing chest drains. You can do it by repeated thoracentesis, but we know that that is associated with a less favourable long-term outcome. There's a higher chance of recurrence, less likelihood of cure if you do repeated needle thoracenteses, and also it's just not as nice for the patient because they have to be stabbed multiple times, and sometimes they need to be sedated for that multiple times as well. So better, in my mind, to do a single procedure, a single sedation or GA, where we place the chest drains, and then those are in, and we can use those for the remainder of the patient's management. If we're putting chest drains in, I like to place them bilaterally, partly because both sides of the thorax don't always necessarily communicate with each other when there's lots of inflammation in the chest. The mediastinum can become kind of plugged with all that inflammatory stuff that's in the chest, and so you might, if you only put one chest drain in, you might be draining one side of the chest, but there's still a great big pocket of pus on the other side of the chest. And the other, perhaps even more practical reason for placing two is because quite often one of them will fail after a day or two, and it's very annoying if you've then got to re-anaesthetize the cat to replace the chest drains, whereas by the time you've done a couple of days worth of management medically, if one drain fails, often you can get away with just having one remaining drain for the rest of their treatment. So I like to place bilateral chest drains, and then I like to lavage the chest once they're in. What I tend not to do is to place those chest drains on the first day that the cat presents, because often these cats are presenting certainly dehydrated, quite often hypovolemic as well, and cardiovascularly unstable. And so when they first present, you're not going to stick a chest drain in the moment you identify that there's pleural fluid. You're going to do a needle thoracentesis, like we just said, to diagnose what the problem is. And at that point, once you've drained the chest, now there's no fluid in there to put a chest drain into. So actually putting a chest drain in straight away is potentially dangerous, because you could hit the lungs that way. So you want to allow time for that fluid to build up again, which usually takes about 24 hours. And so by planning to place the drains the day after presentation, that gives you time to get the cat on some fluids, start your antibiotics, get the cat a bit more cardiovascularly stable, address any electrolyte imbalances that they may have, so that by the time the next day comes around and you're planning to GA the cat is in a much more stable and favourable position to undergo a GA compared with on the day of presentation. So although it often feels like you want to do something straight away to get those chest drains in, it's actually beneficial to wait for a day to buy yourself a little bit of time and get the cat more stable before going ahead and putting those chest drains in. So I like to do that as a planned elective procedure, if you like, rather than doing it when the cat's presenting as an emergency in the first instance. So we actually have a little video here of how to place a chest drain. Now this, for the eagle-eyed amongst you, will notice it's a dog, purely because I didn't have a video of doing this in a cat, but you'll be pleased to know the procedure is identical in both cats and dogs. So we'll just play this video and I'll just talk through what we're doing. So this is using a Myler chest drain, and we're going to use a Seldinger or an over-the-wire technique. And what I was doing there was just measuring how far in I want to place that drain. We're measuring it to the axilla, and the drains have got centimetre markings on them, so you can tell what depth you want it to go into. So we've clipped and prepped this chest, and now we're just placing a fenestrated drape over the insertion point, and I'm just counting the ribs here. You want to aim for either the 8th or 9th rib space, and we're going to place this drain in the dorsal third of the chest. And now this is a dog, and this is the only bit of the procedure that is different in dogs versus cats. I'm just injecting some local anaesthetic here into this dog. I tend not to do this in cats because cats have an extremely low toxicity threshold for local anaesthetics. So you can do it, but you have to be super careful about the amount that you use. And I must admit, I tend not to use local anaesthetic in cats for this procedure. So now we're just going to make a little skin incision. This isn't a thoracotomy, it's just a little nick into the skin using number 11 blade. So just wide enough to be slightly wider than the chest drain itself. And now this is an IV catheter. They come in the chest drain kits, and I'm just inserting that perpendicular to the chest until that pops through into the pleural space. And then I'm angling that down towards the elbow. I've taken the stylet out. You'll notice I covered it there with my thumb, and that's to prevent an excessive amount of air. You will always get some air entering the chest at that point, but just to prevent an excessive pneumothorax. And then I fed this guide wire through that catheter to the second mark, that's 20 centimetres. I've now taken the catheter off the guide wire. That's the bit people often forget to do. But you can't do the next stage unless you've taken that catheter off. And now I'm just feeding the chest drain itself over the wire It's very important to always keep one hand on the wire, because otherwise you can push the chest drain along with the wire into the chest. And that means a definite thoracotomy to retrieve the wire. So that's a disappointing day out if you do that. So try to avoid doing that. So one hand on the wire at all times. Feed the drain in over the wire to the pre-measured depth, and then remove the wire. Again, I've put my thumb over the end to prevent excessive air going in, and then I'm putting a bung on the end. As I say, some air will have been introduced. That's okay. We are going to drain it out afterwards. So that's the procedure. As you can see, it's quite a quick procedure to do, and it's minimally invasive. You do really want the patient to be anaesthetized for it. You can do it under sedation, but I wouldn't recommend that. It's much safer. It's much more pleasant for the patient to do it under GA, and it's much safer because if they do move during the procedure, you don't want to accidentally stab the lungs or potentially other major structures in the thorax. So better to do it under GA.
And once you've got these chest drains in, obviously we can't just let them keep running around. What are we gonna? How do we manage them to try and keep them patent for as long as possible, and also prevent any issues associated with them?
Indeed. So obviously we suture it in after we've placed it, and then we want to put a sterile dressing over the insertion site, the skin insertion point, because we want to try to prevent any bacteria tracking along that chest drain and creating an ascending infection into the chest. And then we also want to minimize the risk of the patient having a good old chomp on those chest drains and chewing the end off, which could result in a tension pneumothorax and could result in death, or just simply introducing infection by a tooth mark, a tooth piercing the drain. So it's good practice to have a Surgifix body stocking over the chest to hold that drain against the chest, so that the ends aren't flapping around, because if they are flapping around, that's when it becomes a bit tempting for the patient to turn around and have a good old nibble on the end of the drain. And then a buster collar I would also consider essential when the drains are in situ, again, to just minimize the risk of the patients chewing the drains out. It's really important that we handle the drains aseptically as well. So when we are doing stuff with the drains, we should be wearing sterile gloves to minimize the risk of us introducing any iatrogenic infections or nosocomial infections through those drains. So here's a picture of the body stocking. These obviously come in all different sizes, so we can get one small enough for cats, and these are generally very well tolerated and definitely minimise the risk of complications from patient interference with the drains. I also like to make sure that we keep the end of the drain as sterile as possible. Nowadays we have these nice little, they're called Curos caps. These are little plastic caps that are impregnated with Hibiscrub and spirit, which is quite nice to keep the bung itself clean. If you don't have those available, you can just as easily double bung the end of the drain, as you can see in this picture here. And the purpose of this is that the outside bung is just simply to keep the one underneath it clean. And then every time that we flush the chest or drain the chest, we remove that end bung and it gets replaced with a new sterile one after we've finished whatever we're doing, so that the bottom bung always remains clean.
We were talking earlier about, obviously we've now got these lovely chest drains in place, and we're going to want to try and deal with some of that lovely infectious material in the chest.
Yeah.
So how are we using these chest drains to aid with that?
So there's different ways of doing it, and I think everybody has their own kind of way of doing it, but basically we want to lavage it in some way, shape or form. So you can just simply drain without lavaging it, but the solution to pollution is dilution, right? So if you're lavaging the chest with with crystalloid fluid, sterile fluid, then it's going to help to break up, especially if the pus is quite inspissated in the chest. It's going to help break it up and get it out of the chest more easily, and will often result in a shorter hospitalization time overall. So it's good practice to lavage the chest. Everyone has slightly different ways of doing it. I like to do it by flushing in 20 mils of fluid, and then withdrawing that 20 mils and then flush in another 20 mils of fluid and withdraw it. Some people will put in a whole, for example, 10 mils per kilo of fluid in one go and then draw it back out. But the reason that I don't like to do that is because sometimes you can get a little bit of a one-way valve effect on the end of your chest drain, which can allow you to flush stuff into the chest but not take it out again. And that's really disappointing if you've then put loads of fluid into the chest and you can't retrieve it because maybe you've iatrogenically made that patient dyspneic then, and that's a very disappointing situation. So I like to do just small amounts of fluid in and out each time. And I like to keep doing that until the fluid comes back relatively clear looking. And you can see from this photograph here, on the left-hand side, that's what we're getting at the start of a round of flushing. And on the right-hand side is what we're getting back by the end. And then I'll repeat that process every 4 to 6 hours, depending on how severely affected the patient is and depending on what's practical for the staff in the practice. But roughly every 4 to 6 hours. And then as the cat improves over the next few days, you can reduce the frequency with which we're performing that lavage. In most of the textbooks, it will talk about using saline for doing that. That's absolutely fine. Personally, I prefer to use Hartmann's because Hartmann's is a more isotonically balanced electrolyte solution than saline. And I have seen quite significant electrolyte disturbances as a result of flushing body cavities with large volumes of saline, which are just a little bit less likely to encounter with Hartmann's. So either fluid is fine to use. Personally, my preference is for Hartmann's. Oh, and I should say, if you find that you are losing a significant amount of fluid in the chest, so for me, if I'm putting 20 mils in, if I lose more than 10 mils of that in any one go, I'll stop flushing the chest there, because what you don't want to be doing is putting lots of fluid in that's just accumulating within the chest and you're not getting it back out again. So I like to have that safety mechanism built in to stop if you're losing fluid in the chest. Often you'll find that you'll retrieve that fluid 4 hours later when you come back to it, after everything's moved around a little bit in the chest, but you certainly don't want to be, you know, drowning the thorax in one round of flushing.
And how long are you giving these cats? So you started your lavage, we're doing it every 4 to 6 hours.
Yeah.
At what point do you think I'm really winning with this, or it's not improving quite as I would want it to?
It's not going to plan. So generally speaking, I would expect an improvement within sort of 3 to 5 days for these patients. And I think for me, if I'm seeing that the fluid is just not improved, well, either the fluid is not improving in its gross appearance and nature over that time frame, or if the patient is deteriorating in themselves, so clinically they're getting worse, they're showing signs of sepsis, they're becoming, you know, cardiovascularly unstable in the face of our medical management, then I would be concerned that we're not winning with these patients. And that's probably when I would then want to have a chat with you, Catherine, about, you know, is it appropriate now to go to surgery? And from your perspective, what would be your considerations for when we would be taking these cats to the theatre?
Yeah, much like you were saying, if we're not winning at that sort of time frame, then feels like otherwise we're going to continue on and down the road and then potentially be in a difficult situation. I think also if we had some kind of suspicion from the beginning that there was something else going on, so if we have you know, if we can ultrasound and we can see that there's lots of consolidated lung throughout, and we're more suspicious that there's maybe an abscess, or perhaps the cat's got a slightly unusual history that we think maybe it is more likely to be a foreign body, although typically we see that much more in the dogs running through fields than we do with the cats. They'd be the situations where we're thinking, yeah, these are probably ones that we might need to get in there and really see what's going on in the chest.
Yeah, completely agree. And just I guess before we move on to the surgery, if we think that maybe we should be looking in more detail, what do you think is the most useful imaging of these patients? You mentioned ultrasound there, and
an ultrasound's probably not going to help us too much more. It might give us an idea that there's something more global going on.
Yeah.
But probably we're starting to think about CT for these cats.
Yeah.
Radiographs might help us to an extent, because we might see one lung lobe that's got lots of consolidation, or maybe some signs that give us a suspicion that there's an abscess there.
Yeah.
But otherwise, really, CT is going to give us that three-dimensional view and really let us have a look at all of the lung lobes in a lot of detail, and potentially even how much thickening there is of things like the inside of the thoracic cavity and the mediastinum that might be propagating this infection more, and maybe why the antibiotics and the lavage isn't getting us where we think we are needing to be.
Yeah, so giving you a bit more idea about surgical planning and what you might be expecting to find in that chest when you get in there. Nice. So, Catherine, if you are taking one of these patients to theatre, can you talk us through what that involves in terms of what are we doing in there? It's all a mystery. They're going to theatre and they come back and some magic happens behind the doors of theatre.
Absolutely. So we typically have two ways that we can go into a chest. We have the median stenotomy, where we come straight down the middle, and then we have intercostal thoracotomies, where we go between the ribs on one side. For these, we're typically thinking about median stenotomies, because these are patients who have something affecting the entirety of the inside of their thorax, and therefore we're really wanting to get a really good view of the entirety of their thorax, and that's something that we're much better at seeing from a median stenotomy than we are from an intercostal. It also gives us that great access once we get in there, not only to assess all of the lung lobes, the pericardium, the heart, and the mediastinum, but also to be able to actually get in there and remove as much of this thickened tissue. So on the pictures that we've got here, we've gone straight through the sternum on both of those images, and we've retracted that nice and wide so we get a really good view into the thorax. We've typically left either the manubrium, the xiphoid, or both intact, because that just provides a little bit more stability to the thorax and to the sternum once we close it back up at the end. Makes these cats a lot more comfortable afterwards. But when we get in there, often we're met with this really thickened, irregular mediastinum, thoracic wall, and pericardium. So we lose that really nice thin sheen that's just a really nice intact thin version of the pleura, and instead we've got this really thickened, irregular material. And the aim of what we're trying to do when we're in there is almost to clear out as much of that as possible. So we're limited on the inside of the thoracic wall. We sort of need to leave that where it is. But the mediastinum, and to some extent even the pericardium, we often end up resecting, and it can be, handfuls of mediastinum, even in a small dog, and maybe slightly less in a cat. But you can definitely imagine that if there's all of these nooks and crannies for the bacteria to be hiding in, that removing those is going to help us get a better solution. And then equally, when we're in there, having a look at all of these lung lobes and looking for any areas of, if we can see an abscess, then that's a lung lobe that we're probably going to need to remove. And even if there's more than one lung lobe that's abscessated, although uncommon, actually we can remove a fair, almost up to half of the total lung volume without causing a big problem. So lung lobectomy is something that we'd consider if there's a specific lung lobe that looks like it's got an abscess in it as well.
Yeah, fantastic.
The other thing that we're doing, much like you with your chest drains, is lavaging the thorax, and partly that's the solution to pollution, but also sometimes there are, maybe more so in dogs than cats, little pieces of foreign material that you haven't seen on the scans, that you couldn't have seen on the scans. And if we really fill that whole thoracic cavity full of fluid, sometimes these things float to the top and come on out. And if we can get those out, then obviously we're minimizing the reason that they have them, and therefore probably more likely to have a successful resolution for the cats.
Yeah, indeed. Nice. Must be very satisfying seeing them float up to the surface.
Absolutely. So yeah, in summary, this is what we're doing. We're looking for an inciting cause, be that foreign material or an abscess. We're taking away as much of this thickened, necrotic, inflammatory tissue as we can. All these fibrous adhesions that we could see on the ultrasound way back at the beginning. If we can break some of those down, then again, after surgery, we're going to be able to drain this chest more effectively. We're going to sort our pollution problem. And again, if we'll also take some more samples, we'll send some of that thickened mediastinum off for culture, because deep tissue culture may give us a slightly different result, or positive result if we haven't had one from our fluid.
Yeah, and that's a good point, isn't it? Because we don't always get a positive culture result from the fluid. So actually anything where we've got a second chance to get the culture result is really useful. So yeah, definitely good to submit that as well.
Absolutely. And very satisfying, like in this picture where we've got a little piece of foreign material that we've removed.
Extremely satisfying. And then you know that you've got the inciting cause out. What are we doing, do you think, in terms of post-op management? Typically, how are we managing these patients following their surgery?
Yeah, so we're expecting them to be relatively uncomfortable, at least in the initial period, because we've taken typically an oscillating saw down all of the sternum bray, or a large number of the sternum bray. And so we're wanting to provide these cats with a strong, probably multimodal analgesia, probably a combination of non-steroidals and opioids in the initial phase.
Yeah.
And also we've now got the advantage of having these chest drains in place.
Yeah.
So actually we can put local anaesthetic directly into these chest drains after we've drained them, and that can then sit within the chest and potentially provide additional analgesia as well.
Yeah.
So we're often using something like buprenorphine, buprenorphine? That's not what I mean.
Bupivacaine.
Bupivacaine down the chest drains at every draining opportunity, sort of every 6 hours, so that we can continue to provide these cats with additional pain relief.
Yeah, and like we said before, just have to be a bit careful with the amount that you're giving if it's a cat, because local anaesthetic can be quite toxic. But yes, absolutely, we do frequently do that post-operatively. And then if you are medically managing these patients and they've got chest drains in, it is important to consider analgesia as well, because although these nice silicone drains are flexible and soft and they're quite narrow, nonetheless, it's something sitting in between the ribs. They still require some analgesia. And typically buprenorphine is sufficient for a cat just with chest drains in. But of course, if they've had a median sternotomy, then we're going to be using full agonist opioids. So we're going to be thinking about methadone for these patients. Sometimes they need a fentanyl CRI, and sometimes multimodal analgesia will include agents like ketamine for these patients as well, at least in the initial phases, won't they? What do we do sort of in terms of more holistic post-operative care for these patients, in addition to beyond the sort of immediate management of the drains and the pain side of things?
So we're keeping these drains in, hopefully by the point that they've been in, had surgery, and we've lavaged it, that amount of production of fluid within their chest should be significantly reducing over the next sort of 3 to 5 days after surgery. And then we're thinking about getting these chest drains out, making sure the cat's comfortable, and then trying to get them home.
Yeah.
We're obviously strictly resting them when they get home. They've had a sternotomy. We need those sternum bray to heal. And we obviously, these cats, we still want them nice and rested and quiet and calm at home. So we're talking probably a small to medium sized dog crate and a litter tray and a bed, and not letting them do all too much more.
Yeah.
We're definitely thinking about antibiotics for sending them home on. We're probably going to keep them on quite an extended course of antibiotics, at least initially. We might change what we're choosing for our antibiotics based on, the first set of fluid that we've sent away, and then maybe even the tissue culture that we've sent away. But often thinking about sort of 4-week courses of antibiotics for these cats once they've come home. And then really trying to monitor to make sure that these cats are improving as we would expect them to.
Yeah.
And often we'll do that through serial radiographs. So we'll maybe repeat radiograph these cats at 4 weeks afterwards, make sure that fluid's reducing. If they're not amenable to that, then we might just, auscultate them, do a general physical exam, and make sure that they're clinically improving at a veterinary assessment.
Yeah.
Maybe stopping the antibiotics at that point, checking them another 4 weeks later, and seeing if they're continuing to improve as we would expect them to.
So you're using clinical signs mostly in conjunction with some radiographs to determine the point at which it's okay to stop the antibiotics.
Yeah.
Because I think this is one of the hard things, isn't it? Is how do you know when is the right time? And do we have any diagnostic tests that we can use that say it's all okay now, we can stop the antibiotics?
Yeah, not really, unfortunately. People keep thinking about whether things like CRP as a global marker of inflammation are going to be useful for this.
Yeah.
We don't really have any evidence to say that it is. And also we've got that added component that we've definitely generated some inflammation with the surgery.
Yeah.
So you can't really tell with your pre-op CRP to your 4-week CRP, is that improving because the inflammation's improving? Is it improving because the surgical side of things are improving? So as of the moment, we're not using that to monitor these.
Yeah.
But it might be something that we have more data about in the future.
Yeah. And CRP, of course, that would only, even if that was found to be useful, that would only be suitable for dogs. We can't measure CRP in cats. So then we know even less about whether we can use things like alpha glycoproteins as inflammatory markers for monitoring cats, don't we? So yeah, really difficult to be able to sort of pinpoint, like, now is the time to stop the antibiotics.
Absolutely.
And so it's important that owners are aware that they just need to keep a close eye on their cat afterwards, because it's possible that if there's still a little nidus of infection left, that the cat could deteriorate again after stopping the antibiotics. I would say that probably in general, we probably have a tendency to overtreat these cats than undertreat them, and when in the future hopefully we do have better diagnostic tests for telling us when we can stop the antibiotics, possibly we treat them for too long.
Yeah.
But we don't know that at the moment, and so typically we're still treating them for around about 4 weeks. So when do we know when we're going to take these chest drains out, either with medical management or post-operatively? When can we say, okay, now it's kind of safe to remove these chest drains?
Yeah. Well, we base it a lot on fluid production, because if we've still got lots of fluid being produced, then we're not going to be wanting to take those chest drains out, because we'll end up back where we started with a dyspneic cat. That being said, the chest drains are never going to be non-productive while they're in there, because we've got this foreign object within the chest that's moving around. It's generating a little bit of inflammation. They have their own amount of fluid that they generate. So when we're starting to get down to sensible numbers like 1 ml per kilo per day, then that's a volume where actually the thorax can probably reabsorb some of that. It's not going to cause a clinical problem. And also we're wanting to see, again, a little bit of a switch in fluid appearance from a kind of pyothorax purulent, even though we said we can't be completely certain, more to a post-operative type fluid, more of a like a clear serosanguinous, less turbid, less opaque fluid.
Yeah,
that's probably an indication that it's just the fluid the chest drain's producing, rather than a significant ongoing pyothorax within these chests.
Yeah, nice. And typically, if we're medically managing pyothorax, we can expect the chest drains to be in for about 5 to 7 days on average. Possibly a sort of a similar, slightly shorter length of time post-operatively, probably. And then I guess it's worth saying that if you're going to have any type of fluid in your chest, pus is the one to have, because it's actually associated with the best outcome in terms of survival rates. And of course, pyothorax being an infectious process, it is a potentially completely curable disease, and certainly we would hope to completely cure these patients. So the survival rate is about 80% in dogs, a bit less than that in cats, just over 60%, and that may be because cats tend to present at a slightly later stage. Cats are good at hiding disease, and we don't tend to see them until the disease is a bit more advanced. But nonetheless, better survival rates with a pyothorax compared with any other type of pleural effusion. And those patients that survive beyond the first 24 hours in hospital tend to be the ones that had a better chance. So often those that don't make it actually don't make it within the first 24 hours of reaching the hospital. And then we can expect a recurrence of pyothorax in up to about 14–15% of patients. So overall, a reasonable prognosis for these patients. So that brings us to the end of our discussion about management of pyothorax. We have a second case for you next month, so join us again then when we will continue our exploration of thoracic emergencies, and we hope to see you then. Thanks very much for joining us for now.